arrange testing for patients, following up on patients, following them in the hospital if need be, or arranging oxygen. Fortunately, I've not lost a patient to coronavirus yet, but some have been fairly sick. So this is a disease we take seriously. At any rate, I don't know if you want me to proceed with the questions I was given in advance, or you want to just give me questions now on the conference, however you'd like to handle it.
Yeah, I'd be happy to pose those for you. Like I said, we have a few extras added, so hope you're ready for them. But we will start off with the best mood boosting tactics you can think of.
So I think the best mood boosting tactics are non-pharmacologic. I'm not anxious to have patients take antidepressant medicine. The best thing is probably exercise. There's good evidence that exercise stimulates endorphins. Endorphins are the chemical in your brain that help release serotonin. And one of the neurotransmitters or chemical in the brain that helps your favorable attitude is to have plenty of serotonin. All the medicines you've heard about in the past, the Prozac and Zoloft and Paxil, those are called serotonin reuptake inhibitors. They block the metabolism of serotonin so that it raises a higher level in your brain. Next to that, there's good studies to say that fresh air is advantageous, and especially exposure to nature. When people are exposed to nature, whether they can either even get physically outdoors or in the hospital setting, we have photographs in the room of nature, that seems to boost people's spirit. So I think those are probably the best things. Of course, associating with friends, which is a little more difficult during COVID, but if you can do your own Skype calls or FaceTime or whatever, that helps. And having a sense of humor. There was an article, or book actually, by Norman Cousins, who used to be the editor of Saturday Review, an old magazine. And he spent his time, whenever he was feeling down or blue, just watching old movies, especially things like Charlie Chaplin and so forth. So if you can get a hold of a humorous video or movie or book, that should help as well.
Great, thank you. I think by now we've all got a Netflix subscription too,
Definitely.
So we've got tons of funnies at our fingertips. Next question, what is the safest way to purchase the items you need for a healthy meal?
Well, the safest is not to go to the to the grocery store. If you can order online, that's probably the best. Whether you want to get organic food or not, I can't tell you if it's much safer. You know, much of the concern about coronavirus initially was fomites. We were worried what we touched. And we found out that's not the way the disease is transmitted. So yes, it's still good to practice hand hygiene and avoid touching too many surfaces, and wash your hands carefully when you get home. But I think if you take care and you can wear a mask when you go into the grocery store, try not to go during peak hours. I know they have senior hours for some people, and take advantage of that. Otherwise, if you can order online, that's probably the best way, and have it brought to your house.
Yeah, this isn't on the list, but just to follow up, should you be concerned at all with like ordering delivery and that contact? I mean, you just said it's not really spread through contact, so you think delivery is pretty safe?
I think initially people were, washing the cardboard boxes that came into their house and so forth. That may be a little excessive. Sure, you should wash any fresh fruit and vegetables, but as far as decontaminating the boxes or worried about the person who carries it into your house, if they can leave it outside, that's ideal. But I wouldn't worry too much about that.
Okay, great, thank you. Next question is a new one. It's what is proning or proning? P-R-O-N-I-N-G.
So proning is when you lay down, you're either supine or prone. When you're supine, you're laying on your back. When you're prone, you're laying on your tummy. But we found out that the lung capacity actually is increased by laying on your tummy. So when patients develop COVID and they have compromised respiratory function, their lungs are so full of fluid and infection, mucus and so forth, we actually get better drainage and increased lung capacity by laying them on their tummy. So we have special beds, we have special turning techniques. The nurses are trained in this now, and many hours a day, a patient will be basically laying on their tummy if they have severe COVID. And that's allowed us not to intubate patients as much as we used to, and we have decreased mortality as a result.
Oh, okay. That's strange. I haven't heard more about that then, if it's helpful for COVID.
It's a fairly labor-intense thing because, the number one loss of nursing time other than COVID exposure these days is, bad backs. And when they have to take these patients who are virtually immobile and flip them over, it takes a fair amount of labor. So you're often calling in 3 or 4 nurses to try and help. Now we have these fluidized beds, which basically can be pressurized to turn the patient somewhat, so it takes the pressure off the nurses. But you think it'd be uncomfortable laying on your tummy all day, but you actually breathe much more efficiently. You get better oxygenation.
Wow. Okay. Thank you. Next question. As someone who enjoys spending long periods of time in warmer states, how concerned should I be with breathing in air in areas experiencing forest fires? So this is a little bit from the earlier, every year warmer states get forest fires. So how concerning is that?
Well, when the California fires were at their peak, the air quality was the worst in the world, worse than Calcutta, India, or other places where, familiar with it, have poor air quality. And the small particulates, these small particles, when you're burning, get into the lung and irritate the lung. And even in patients who don't have asthma, they can trigger irritated airways and chronic bronchitis, chronic coughing, spasm of the airways, asthmatic reactive airway disease. Most of these are transient, temporary, but some of the patients have persistent problems. So in fact, we told people at that point they were safer indoors than outdoors. So you would hate to go to an environment where there are forest fires, but once you're there, you have to try and shelter indoors. Wearing a mask sometimes will filter out some of the particles, but the small particles can be quite irritating. So you can't avoid it once it happens. If you're in that environment, you can't get out. But it is a concern, and that's why we're all in favor of getting rid of small particulates in the airways, burning fires, trying to prevent forest fires, keeping children out of that environment because that triggers asthma in children especially.
Yeah, okay. Great. And next question, another kind of shift in gears. I'm concerned about a new mole on my arm. Should I get it checked out, or is it just kind of things that happen as you age?
Well, one day a week now, because we don't have capacity in our office, I actually am home. Today's my day at home doing video calls. So I've had patients, in fact, I had a patient this morning who emailed me a picture of his rash. So it's amazing how much you can diagnose over the phone or video these days. You may want to just call your doctor or dermatologist or whatever, and you can do a pretty good close-up with your iPhone or whatever you're using. You can't always tell the texture. You can't feel the subcutaneous tissue, obviously, by phone. The 4 criteria we really worry about are a mole, and this is a type of mole called melanoma. Melanoma is a kind of a skin cancer that can be fatal. It can spread into your internal organs. So we use the ABCT criteria. A stands for asymmetry. So if you were to take the mole and transect it in half and you don't have a symmetric, equal mirror object on each side, that's potentially worrisome. The B stands for borders. If the borders are irregular, that's potentially worrisome. C is color. If it's not just light brown or dark brown, but multicolored, brown, blue, red, black, that's worrisome. And then D is diameter. That stands for the size. Usually it's more than about a centimeter or about a pencil eraser in diameter. So if you meet several of those criteria, that's potentially worrisome. As we get older, we get all sorts of little skin ditzels and things. And very commonly, you have something called the seborrheic keratosis. It looks brownish. It's slightly elevated. It's kind of greasy. If you pick at it, it'll actually bleed. It can come off and regrow. Those are nothing to worry about. But if there's a sun-exposed area, especially over your face, your nose, the top of your ears, the back of your hands, that has changed in color and is growing rapidly, then you should definitely see your doctor.
Great. Thank you. Yeah, that's a really good, potentially life-saving thing. You got to get checked out. So thank you. Next question. So the medical clinic that I have been attending for 30 years is closing this week, but I'm able to transfer to another clinic within the network at my age of 70. Should I try internal medicine or family medicine?
Well, it's a difficult condition. I don't want to set up a turf war. I'm trained as an internist, and in internal medicine, we do a residency training primarily, exclusively in taking care of adults. So we don't do obstetrics. We don't do pediatrics. So our time is spent entirely training with adults. Family practice does a little more training with pediatrics and some obstetrics. So, but otherwise, they're comparably trained. They are good family practice doctors. Internal medicine in a sophisticated urban environment are considered the doctors for adults. Family practice it traditionally was more in the rural areas, but there are very well-trained and good family practice doctors in town here. And I would think they're fairly comparable. It's always hard to tell how qualified a physician is until you meet the physician and see how your personalities mesh. But also it's advantageous to know where their training is. And if they've trained in a reputable medical school, had a residency in a sophisticated hospital setting, then you have more confidence. Some people look down on doctors who trained overseas. It's somewhat hard to evaluate how good the training is overseas. But there are many good doctors that come from especially India and Asia now that are well trained. So I think you have to look at recommendations. Sometimes you get a recommendation from the county medical society. You talk to other friends, you talk to other physicians who may be familiar with this doctor, and then you have to make a choice once you meet the doctor.
Yeah. Okay. Thank you. Next question is one we've gotten quite frequently. Probably the most common question we received. So some people have, some people haven't traveled outside of Minnesota, but should I travel outside of Minnesota before a COVID-19 vaccine is approved?
So this all has to do with how much risk you're willing to accept. Whenever you travel, even when you leave the home, there's always a small risk. If you wear your mask, although it's more to protect other people than yourself, but it may have some advantage in protecting yourself. If you wash your hands frequently, if you can avoid crowded indoor environments, there is less risk, but there's always going to be some risk. The jet airplanes have a very good HEPA filtration system that usually we've not seen big outbreaks on jets, but it's the waiting in line, it's the environments on the way to the airplane. If you have to get in a cab in a closed environment, those things are kind of worrisome. So I tell people it's somewhat risky to travel, but not a major risk. When you get to an environment and you can be outdoors, if you're going to Florida or Arizona or something, to some extent, you may be safer once you get there because you can be outdoors and there's much less exposure outdoors. So you have to trade off a finite period of increased risk with a much longer beneficial. To be here in Minnesota all winter where we're exposed indoors may be more worrisome than being outdoors in Arizona. So it's a balance you have to decide on your own.
Yeah. And this question from the chat mentions driving. Is that any safer?
So some people have tried to quantify the risk, and they say if you have to spend more than one day in hotels and so forth, that the risk is about comparable to flying. In other words, if you can fly and fly overnight or less than one day on the road, it'll be about comparable. If you have to spend several nights in a hotel, then you have to check out, ideally, if the hotel, if you can get a room that hasn't been occupied for 24 hours, that's advantageous. Some of the rooms have special cleaning protocols, and you want to make sure they adhere to that. You don't want to be in an indoor environment, paying for groceries or something like that if you can avoid it at a gas station. But otherwise, again, it's fairly comparable as long as you don't have to spend a long trip on the road.
Yeah, really great information. I think traveling is something everyone is itching to do in some capacity, so that's really helpful to know. Another question from the chat. I have a CPAP machine, but rarely can make it through the night with the mask or even after 1 year of use. How important is a CPAP machine, or are there other better sleep options?
Well, this is somewhat complex. We do run into this a fair amount. In fact, I got a call today from somebody who was out of town and forgot a CPAP machine, and we had to arrange it. It was so bothersome for him not to wear the CPAP machine. So it partly depends on how severe your sleep apnea is. And there are ways of quantifying it called the apnea-hypopnea index and so forth. So if you have severe sleep apnea and you go without it, first of all, you'll have a bad night sleeping and you'll be tired the next day. But when people are tired, they have increased incidence of auto accidents. They have more hypertension. That can lead to strokes and so forth. So if you only go without CPAP a few nights, probably not too bad. But if you have severe sleep apnea, it could be potentially deleterious to your health. Some people just cannot tolerate CPAP, and that's why we have oral appliances. So there are ways of wearing almost like a mouth guard, a football mouth guard that pulls your tongue and jaw forward so that your tongue doesn't collapse into your airway and obstruct the airway and interfere with the breathing. That's the simplest and the cheapest. Often a dentist can do that for you, or there are special maxillofacial surgeons, oral surgeons who do that for you. Here in Minneapolis, I don't want to give a plug, but the Snoring and Sleep Apnea Clinic is probably the best known. Dr. Jonathan Parker Parker and his associates, but there are many other people who do that. So that's a simple way. There are more aggressive things, and there's another company called Inspire where they actually implant a pacemaker sort of into the body that contracts the pharyngeal muscles to pull the tongue out of the way, and so you don't have the sleep apnea. There are procedures where they take excess tissue off the back of your throat, your pharynx, your tongue, somewhat painful operation called the uvuopharyngoplasty, and that has moderate effect. Of course, sleeping on your side would be the easiest. The old-fashioned trick is what we call the tennis ball trick. We used to take a t-shirt, a very tight t-shirt, and sew 3 tennis balls right down the spine. And so when you lay on your back, the tennis balls jab into your spine, then you turn on your side. A lot of people don't have sleep apnea if they don't sleep on their back, but that's only for mild sleep apnea. So there are many ways around it if you can't tolerate the CPAP machine. Also, they have newer CPAP machines. Some are tolerated better than others. Some just go over your nose rather than your mouth. So if you talk to your CPAP supplier, they can often make adjustments for you.
Great, thank you. It's interesting you mentioned Inspire. Actually, my best friend works for Inspire, so.
Well, I hope they give me some stock options. Good.
Okay, our next question is, since so many hospital staff are getting sick, why haven't we quarantined hospital staff to the hospital? Could hospital staff be the spreader? And should hospitals be run by military so staff exposed would remain on site instead of going home?
Well, this is a difficult question because we're so short-staffed. They're trying to decrease the time we have to quarantine people if they're exposed. But actually, when they've looked at the amount of COVID in at least in a clinic environment, we're actually safer where we work than most industry because we wear masks all the time and we wash our hands all the time and we separate ourselves. So hospitals have tried to separate the COVID from the non-COVID patients. They're pretty rigid about that. If you have a fever, if you have a cough, you have any semblance of COVID, you don't get to go to the main part of the hospital where we take care of the non-COVID patients. Ideally, we're asking our staff if they have any fever, cough, sore throat, any of the early manifestations of COVID, which are quite minor, not to show up. So it's not impossible that a COVID nurse or doctor could be spreading it because you're asymptomatic. The first 2 days you have the infection, you can still spread the COVID virus. But we're all wearing masks. We try to keep our social distance. So I think the military didn't have a whole lot more luck anyway. If you read about their contacts in the Coast Guard, ships and so forth, Navy, they've had their own problems with COVID. So we have not gone to quarantine hospital staff. There are places where they've had COVID hospitals totally separate from the non-COVID hospitals, and that works out well if you have the staffing and the facilities to do that.
Great. Thank you very much. Another COVID question, I'm guessing that's going to be the theme of today. What do you see our COVID experience changing in terms of future telehealth and in-person doctor visits? I know you said did you say it was 1 day a week that you're currently doing telehealth? Do you expect that to continue after COVID?
Well, the big determinant, of course, is going to be payment. So far, the government has allowed, we never were allowed to bill for a telephone call or a video visit over Medicare. And of course, as a internal medicine physician, although I see probably equal number of patients under 65 as I do over 65, the patients over 65 appear in the office about 4 times more often because they have more illnesses. So that was a large part of the population that we would only either see in the office or handle by phone at no charge. Now that we can at least capture some revenues, I think that it may be more common to see the video call and the telephone call part of our practice. I am not totally enthralled with the system because I can't examine the patient. I can't listen to their heart. I can't feel their abdomen. Even taking blood pressure is somewhat questionable when the patients read me their own readings. So I'm not sure it's the best medicine, but there are some problems that can be handled exclusively by phone or video. So I think payment is going to dictate whether this becomes a large part of our practice. I think that answers the question. Yeah, okay.
Great. And then we have a little bit of a change in questions. So what advice would you give your younger self in terms of incorporating healthy habits into your lifestyle to prolong your lifespan and stay healthy longer?
Well, I'm not sure I'm the best one to give advice. My dad's 100 years old and my mom is 97. So if I gave myself more advice, I couldn't do any better than they did. But at any rate, all these things we talk about, preventative health, which is a large part of my business. Try to get adequate sleep. There's, people in modern society, once we invented TV, electricity, and so forth, they think they can get by with 5 or 6 hours. You have to try to get at least 7 or 8 hours. That certainly helps. We know that people that are underslept have a little more higher incidence of illness, hypertension, so forth. Trying to eat a well-balanced diet. Half your plate is supposed to be fresh fruits and vegetables, or we say 4 to 6 servings of fresh fruits and vegetables daily. And then a minimum of a half hour of exercise or possibly a little bit more every day is beneficial. So if you get a good diet, if you get adequate rest, and if you get some exercise, those are probably the 3 main things we can try. And of course, not doing things that are bad for you, which is smoking, probably the worst, and excess alcohol consumption.
Yep. Those are the things, we know, but we got to just stay on top of it.
Common sense things, and people always ask, why do I ask these questions? But people who have guns at home commit much more suicides. So firearms, I'm somewhat opposed to unless they're locked up and ammunition separate and so forth, especially in a depressed patient. Wearing your seatbelt, bike helmet if you're a biker, excess sun exposure, just like you asked about skin cancer, a mole that changes. Obviously, you want to prevent those things. So just those sort of common sense things. And then getting your immunizations. I have to preach this time of year. We have a hard time differentiating influenza from COVID when it first comes in the office, because you get a cough, you get a cold, you get a fever with influenza. So getting your flu shot this time of year is strongly recommended. There was a commentator on today that said vaccines are probably the best invention of mankind. If this COVID virus vaccine works and we're able to conquer the disease within a year, it's going to be a miracle.
Yeah,
and get your vaccinations. That includes diphtheria, tetanus shot. This for older folks, we give a pneumonia shot. Shingle shot is for after age 50. Those kind of things are beneficial.
That's actually a great segue. I just got an email of a question to be added. Is it safe to go get those, even your flu shot when going into like CVS or something like that? Or should you exclusively be going to your doctor for those at this time?
Again, it's just a matter of exposure. If they have a protocol where you're in and out of the drugstore fairly, quickly, it's more important you get the shot than not get it at all. We try to have flu clinic days where we have people just come in for flu shots. They're in the office, they're out of the office, and so they get minimal exposure. But for instance, in my office, some people have to ride the elevator up. That's exposure. I take the stairs every day, but they take the elevator. So any type of exposure, the less exposure, the better. It doesn't. I think they do a fine job at the pharmacies, but the more important that you get it. And it takes about 2 weeks from the time you get a flu shot till it's effective. Fortunately, we've not seen much influenza yet this year. And in the southern countries like Australia and South Africa, they've reported some of the lowest influenza they've ever had. Why? Because people are washing their hands and they're wearing masks. So probably it's not that we have such a great influenza year, that it's a very weak virus this year. It's just that people are being more cautious. But it still would be a good idea to get an influenza vaccine, because if you get sick, number one, we'll know it's not influenza, or probably not. And number two is you would hate to have a twindemic, we call it. To get simultaneous influenza and COVID could be devastating.
Oh yeah, that would be horrible. Yeah, and we have a few questions in the chat. So or in the Q&A section, which is available to you too if you want to use it. It's on the bottom center of your Zoom screen. And I'll throw that to Anthony just to get a break from my voice.
Well, thanks, Lauren. Hi, Dr. Kaufman. I'm going to read off some of the Q&As, and thank you everybody for your patience as you've been asking questions. We're kind of going back and forth between our list and the ones that have come in live. So our first question, this one's a little technical. So it's, have any of your COVID patients, doctor, had a drop in temperature, i.e., something akin to 94 or 95 with a decrease in oxygen levels to the low mid 80s, which is a very specific question, but they're wondering about that.
Yeah, I'm not sure this is going to be a great universal appeal. Of course, the big concern in COVID when it becomes serious is if your oxygen saturation drops and stays down there. You have to be somewhat careful, because when you wear an oximeter, and most oximeters are on your finger, if your finger's cold, it gives a very false reading. So you got to make sure your finger's warm. And I just wonder if when they say the temperature drops, if they're really getting a core temperature. So the temperature under your tongue is much more accurate. The infrared meters that we shine at the forehead are very inaccurate. Some people have an oximeter that clips to their ear, which is pretty good. But of course, it's only a reflection of what the oxygen really is. The true oxygen measurement has to be done with an arterial blood gas, which involves a stick into your artery, which is no fun. So it's uncommon that your temperature will drop and your oxygenation would drop. When people are in shock, their temperature can drop. Most people, when they're fighting off an infection, they shiver, and the shivering is contracting your muscles, and that tends to raise the temperature. Of course, if you take a lot of Advil, Nuprin, Aleve, any anti-inflammatory medication, that's going to temporarily drop your temperature. There is something called a crisis and a lysis, where you'll have a high temperature, then you'll chill, you'll sweat, and your temperature will drop subnormal. And that's part of the body fighting off the virus, and then it normalizes. So I'm not quite sure what that person is describing with the low temperature and low oxygenation. Yeah.
Yep. And here, this is actually a perfect question, because we've talked about vaccines, we've talked about exposure to the illness, and the question is basically about immunity. So I'll read it word for word here. Today, I heard a woman who recently recovered from the coronavirus say she doesn't have to be careful anymore, that she won't need a vaccine, that she can be with whomever she wants, whenever she wants. Is that true? And I'll add on my kicker. How does the immunity work, as best we understand it, if you've already had COVID-19?
Well, she may not be entirely incorrect. You may have heard about the head of Sanford Health, or vice president, I guess he was, who just got fired because he had COVID and says, I don't have to wear a mask anymore. The problem is we don't know how non-infectious people are who've had COVID. I think she's probably right that she's probably non-infectious, and she probably won't acquire a second case. There have only been a couple cases in the world literature of people who've had COVID so far that have had reacquired it, and even those, the documentation is somewhat poor. So, but the problem is, since we can't label people, I'm COVID free or not, we still encourage people to wear a mask and, not take their chances. There are other respiratory viruses out there. I always said at the very beginning of this, I'd love to have a mild case and not have to worry about it. But in our office, when there's any questionable patient having COVID, we not only have to wear a mask, but we have to wear a half respirator, which is this big thing with goggles and air vents, and we have to gown, and we put on our gloves, and it's a time-consuming type thing. So she's not entirely wrong as to whether she should have a vaccine or not. Again, with the vaccine shortage, it would be interesting if we prioritized people who never had COVID to not have the vaccine and wait for the people who never had it to get the vaccine first. As far as how the immunity works, initially you develop what's kind of liquid immunity called your immunoglobulins, but subsequently your T cells have a memory of the COVID virus, and they will activate if they're ever exposed again. We don't have a great way of quantifying how well the T cells work. So this individual who had COVID, even if she had a high immunoglobulin level, and by the way, we don't even know when we measure antibodies, if we're measuring the right antibody, what level of antibody is protected. So she may be taking her chances to be exposed to others, and for T cells to not trigger properly, she could acquire the disease later on. At this point, we think most people who have had disease are probably safe for 9 months or a year, but the disease has only been around for that long. So we just don't know yet how long immunity is going to last, and we don't even know when you get the vaccine how long it's going to last. The good news about coronavirus is it does not mutate as quickly as influenza virus. So we think the vaccine may last several years. As you know, influenza vaccine, we have to change it every year because it mutates quite rapidly.
Yeah, thank you for that answer. Quick question. Don't know if this is in your realm at all, but we have a question wondering about what happened to Bethesda Hospital, the COVID hospital. Why was it closed? And I don't know if you have any analysis on that or not.
I'm not a doctor in the Fairview system, but as I understand it, that was a Fairview hospital. Because of the tremendous losses people are taking from decreased surgeries and occupancies of the remunerative types of hospitalizations like coronary bypass and orthopedic surgery and so forth, they weren't making money. COVID was a money-losing proposition, and they decided to close it because it was not financially viable.
Yeah, thank you. Excuse me. Next question, does the MDH, Minnesota Department of Health, saliva COVID test, which I would understand that is one of the saliva COVID tests that have been going around from the various distributors, include a flu test? I thought I heard the governor mention that as one of his press conferences. So when you take a saliva COVID test, are you also being tested for influenza?
No. Okay, not at this point. We are going to have Well, actually, when we now want to do both a flu swab or test in the office and a COVID test, we have to use 2 separate collection vials and so forth.
Sure, sure. Next one, I'm going down my list here. Okay, well, a little bit more of a technical one. Again, we're talking about the vaccine here. And specifically, it's asking, I understand most of the messenger RNA biochem, which congratulations, you're probably the only one in the call that totally understands it. But I wonder if you could explain it in plain English. Exactly. So we're talking about how this vaccine might actually work.
Well, I'll maybe do it backwards. So there's the 3 main vaccines that we're going to see out, I think, initially is going to be the AstraZeneca virus, which is basically a killed virus, traditional virus that they're working out of Oxford, England, and AstraZeneca. And the advantage of that one is that it's very easy to produce. It's very cheap. It doesn't have to be refrigerated or not to any degree. And we're used to that vaccine because we know it's worked in the past. And most of our vaccines have been modeled under that kind of killed virus, just like the influenza vaccine. The problem is AstraZeneca had a little problem with doing their proper testing, and they gave the wrong dose, and they may be redoing it. But that is that's the traditional vaccine. The 2 other vaccines that may be coming out very soon is the Pfizer vaccine and the Moderna vaccine, and they're based on a particle of RNA, which is ribonucleic acid, which is a protein that they've encoded to replicate what looks like the spike protein in the coronavirus. So in order to penetrate your cell, the coronavirus has this little spike, and then it gets into your cell and causes it to take over the replication of proteins and so forth, and makes you very sick. So if we can prevent the spike protein from getting into your cells by blocking it with this messenger RNA, it prevents the disease. We've not ever had an mRNA vaccine. They're somewhat difficult to make. As you know, the Pfizer vaccine requires tremendous refrigeration, and it's going to be a logistical problem to get to keep the vaccine cold and get it out to the public and without warming it up and losing its potency. The Moderna one, I guess, is not quite as finicky, but if it works, it's going to be a real miracle of modern science.
Yeah, absolutely. We have a couple more from the chat, and then I'll let Lauren get back to the pre-generated list. One is, what is likely, and this may be a little bit down the road before we know, but what is likely to be the best vaccine for a person with a severely suppressed immune system due to a transplant and the medication which follows? Is that known yet?
No, so we don't know. We have no head-to-head studies. A lot of the doctors are saying that if you can get the vaccine, get whichever one you can get the soonest. Now, the AstraZeneca percentage of protection did not initially report to be quite as efficacious as Moderna or Pfizer, but we just don't have head-to-head comparisons. If you're immunosuppressed, most of the vaccines are going to require 2 shots, and you will not have full immunity till you get the second shot. The second shot may actually be more important. And then there's the other question: if you are on immunosuppressive drugs, should you temporarily suspend them in order to get good antiviral titers to make sure the vaccine really takes? In other words, if you're on a suppressive drug, the vaccine may not work as well. So those things still need to be determined. We have these super high dose influenza vaccines for the elderly and people who are immunosuppressed. Is there going to be a special coronavirus if we're not sure the virus will take as well in an immunosuppressed patient? That has to be seen. So there are a lot of unknowns that I just can't answer yet. Yeah.
Yep. Got it. And now we'll get out of the specifics a little bit and get to a question that I think is on everyone's mind this year, which is, I'll set up the scenario as it was asked. Our daughter is a principal of a middle school in Chattanooga, Tennessee. She and her family want to come home and stay with us for Christmas. What are your thoughts? Should they get tested before they come? And I'll expand that to, how do you feel about traveling for the holidays, families coming together? What side of the best practices, or should it not be done at all?
Now, this is a very difficult quality of life issue, because even if you get tested, that's only one point in time. So as I may have mentioned before, so from the time you acquire COVID until you're symptomatic is about 5 days. You can shed the virus at least 2 days before you become symptomatic. So if you get tested and you don't have any symptoms at all, and you're lucky enough to have been, or unlucky enough to have been exposed to COVID and not have symptoms, you might be able to pick it up early. If you've had symptoms and you get tested and you're negative, you're positive, obviously you shouldn't be traveling and you shouldn't be exposing anybody. But the problem is the people who got exposed either en route or just a day or two before they left and after they got tested and they come here, they could still develop COVID. So ideally for the first several days when they're here, they should be quarantined or not exposing you. So again, it's a matter of risk. If you say, well, of course we're going to have the party together and they're not going to be quarantined, you are potentially exposing yourself. If you can do, and we've done this even in our family, we added a leaf to the table, we opened up the windows, we had the kids wear masks, and we stayed as far away as we can. We try to minimize the risk. Fortunately, my grandchildren had been out of school for at least a week before Thanksgiving, so I wasn't exposed to as much as had they been in school. But there was risk and we took it. I'm not sure it was the best idea. If you asked Dr. Fauci, he said he didn't have anybody home for Thanksgiving. So that's the way it is, yeah.
Yeah. No, I think that's going to be on everybody's mind this year. I'm going to hit 2 from the regular chat, and then I will throw it back to you, Lauren. Question, I'm a healthy 88-year-old female. Lately, I periodically feel a bit lightheaded and seem to have some balance issues. The question is, do you have any comment on this? But, what would you maybe recommend as a first step?
Fairly common problem. Unfortunately, as we get older, our balance isn't what it used to be, which is why people should be using cane or walkers for stability. I tell my patients, don't get up on step stools or chairs. You see as older folks walking slightly bent forward, watching their feet, that does affect their center of gravity, which isn't the best thing, but they tend to shuffle more. They tend to hold their feet further apart just for stability. In order to have good balance, you have to have good vision. You have to know where your feet are in space, and the transmission of the nerve impulse from your feet to your brain isn't as quick as it used to be. Some people develop neuropathy, so they can't feel their feet. Their hearing isn't good as it used to be. So balance is often multifactorial. We worry about little strokes or hardening of the arteries, especially in the cerebellum, that affects your balance. So this is not uncommon. If you are truly staggering, if you cannot, if you're falling frequently, if you just can't maintain a good balance, then you may want to see your doctor. Most of these things are not, even if we do a brain scan, they're not terribly treatable, but you can go to physical therapy and work on balance, work on your posture, work on gait training devices to prevent falls. Falls in the elderly are quite potentially devastating. A person who falls after age 85 or 90 breaks a hip, often 25% of those never walk again. They're in nursing homes and they never recover. So if your balance is really poor, you should see somebody and at least get physical therapy.
Thank you. Last one from the chat, at least as it's been written right now, and you touched on this earlier with the mutation rate. Are there different strains of COVID, A, B, C, and so forth? And will the vaccines cover all of them?
Yes, there are different strains of COVID. There's been some hypothesis that the virus they had in Wuhan is actually in China, where it initiated, we think, may have mutated and become more virulent, more potent. Having said, though, the vaccines that we have right now, it looks like they cover most strains. The part of the strains that we're measuring is not the spike protein, it's the part of the body of the virus. And just because they're different strains, that has not affected our ability to make a good vaccine. But if the spike changes or if the virus mutates radically, then we will lose the ability of the current vaccines to be effective, or they'll diminish in effectiveness. Then we'll have to start developing new vaccines.
Excellent. Thank you. Well, Lauren, I've gotten through all the chat questions. Head to it with the list again. Thank you, Dr. Kaufman.
Yeah, we've got plenty on the list too. So you can keep asking your questions, but we're going to keep working through the list. And if we don't get through all of them today, just know we appreciate this so much. You can hopefully we'll have an event like this again, and we'll be able to do something similar, since clearly we've all got tons of questions. So we'll get going. The next question is, with gyms being closed and the weather getting colder, what's the best way to exercise that you recommend?
Well, I know the Peloton people, I think their sales went up by a factor of 3. You cannot even get most home exercise equipment. Some people have availed themselves of the gyms that are closed, and they're actually renting like the exercycles, bikes and things to use outside the gym. They figure as long as it's sitting there, not earning revenue, people can bring it to their home and use it. If you dress properly and go outdoors, fortunately in Minnesota up till now, except for that snow we had in the end of October, it's been fairly pleasant. If you dress properly, you can walk outdoors. It's not slippery yet. Try and take advantage of the dry weather we're having right now. Other than that, there are lots of apps on your TV, video, whatever, where there are exercise programs. If you can get yourself even a small amount of weights at home, resistance bands, steppers, whatever you can get a hold of to get exercise in the home. If you have to, people say, well, should I go to the mall? The mall, again, it's an enclosed environment. There are a lot of people there. Some have hours first thing in the morning where they're just for walkers. If you could take advantage of that, that might give you somewhat less exposure. So whatever you can find that keeps you active, but you should try to get your minimum of a half hour of exercise daily.
Kind of a piggyback question to that, but how important is vitamin D? Obviously going outside is, usually it's always every year as a Minnesotan, difficult to get as much outside time as we'd like, but how important is that vitamin D?
Well, vitamin D is probably oversold. I mean, we call it the sunshine vitamin. And in the summer, 20 minutes of sunshine on most of your body gives you adequate vitamin D. The skin converts vitamin D into its active form with sunshine. So in the winter months, I'm not opposed to having people take vitamin D. 1,000 units daily or so is probably all you need. Most dairy products are fortified with vitamin D. So if you eat dairy products, you're probably getting vitamin D. The vitamin D industry, actually there was an expose in the New York Times a couple years ago. A lot of this was financed by the vitamin D industry, and doctors were paid off to testify how efficacious it was. So I'm a little bit suspicious about some of the claims. When they've given high doses of vitamin D, it did not help prevent heart disease or cancer. So although people are deficient in vitamin D, and we often give them vitamin D, whether they really improve their health, longevity, has not clearly been shown to a large extent.
Okay. And then we've got kind of a few questions all saying about the same thing. And obviously you might not know, but questions along the lines of how long do you think this will last? Do you know when, any better idea when a vaccine will be available?
I probably don't know better than most of your audience there. Supposedly they have 20 million doses. The government, paid in advance to have these doses ready. So we weren't even sure that it was going to work. But I think Moderna has 20 million. I think Pfizer may have 20 million. I know they're promised to the healthcare workers, probably to the nursing home residents or at least staff initially, because those are the ones who may have the most benefit. There's some controversy who should get it next. Do we give it to younger people who tend to spread the virus more? Do you give it to the older folks who have a higher fatality ratio? Of course, immunosuppressed patients who have higher mortality. So that's being decided on a state-by-state level. I think we're going to see some immunizations this month. We may be able to get maybe 20, 30% of the population immunized in the first 3 months or 4 months of 2021. If you count that 20% of the population maybe already has some immunity, and if you get another 20 or 30% immunized, you're getting up to around 50%. We think once we hit 60 to 70% herd immunity, the virus becomes much more difficult to transmit because people already had it, so they're not spreading it as well. So then the rate starts declining. So I'm hopeful that maybe by late next summer, we'll start seeing a decrease in propagation of the virus and incidence, and maybe we'll be able to get by even without wearing masks in next fall. Who knows? All right.
A light at the end of the tunnel.
Yeah.
Okay, I am feeling fine socially, but how can I best be helping those in my life who seem to be struggling with those and with that issue? And similarly, how can those who are retired but are struggling with social isolation? Yeah.
Well, this is sort of unheard of in our lifetime, but fortunately we do have some technological advantages. If you can get any elderly set up on Skype or FaceTime, if you can arrange even distance meetings with them, whatever you can do to take them out in a distance type setting, if they can get down to the lobby and sit 6 or 8 feet away from other people and just watch other people going by, having them look at nature, getting them photos of nature, talk to your friends via Skype or FaceTime, whatever you can do. But it's the social isolation is very difficult. So you just have to transmit that you love your friend or loved one and try and stay in touch as often as possible.
Yeah, thank you. Are you seeing a lot more, personally seeing a lot more struggles with mental health?
Yes, unfortunately, we've seen a big increase in depression, anxiety. Unfortunately, I've heard there's more domestic abuse and other bad things associated with people being cooped up indoors together. So it's people say, well, gee, I'm depressed. Can I take medication? This is not necessarily the kind of depression that responds to medication. This responds to social interaction, and you have to try and arrange that as best you can.
Yeah. And we did get a chat question. We kind of touched on this a little bit before. So actually the physical containers of takeout wouldn't be an issue, but is it safe to order takeout in the sense that someone's preparing your food?
Again, we have not seen food transmit COVID. So, I mean, people say, well, how do I know the chef is not coughing on my food and spreading coronavirus? Probably the gastric acid in your stomach would destroy it anyway. So I think it's pretty low risk to take out food and acquire coronavirus. That's fairly safe, I believe. The act of going out and being exposed to others, if you have to go into a restaurant with a bunch of people waiting for them to, because they're so overburdened to finish your meal, that's probably a much bigger risk.
That's the silly thing I've seen a few times is I'll go to pick up something and the amount of people closely waiting for their order is way more than if I would have sat down, I think. But yeah, there's always delivery. Next question, why are there differing opinions about masks? Isn't this basically just a medical topic?
Yes, well, I actually was listening to a podcast yesterday about Andy Slavitt, who's one of our local boys, but used to be the acting head of Health and Human Services, has a podcast called In the Bubble. And he had just gotten off the phone with the head of the British Health Service. And they said, why do you have a problem wearing masks in the United States? And he said, it's political. And that's the problem. It became political. It shouldn't have become political. But somehow, you know, the people who want to be libertarians or independent thought that if they don't have to wear masks, they don't have the government telling them to wear masks, then they're expressing their political independence. This is really a medical issue. We know that people who don't wear masks are more likely to spread the virus. And so if people can be conscientious wearing masks, we could save, you know, probably 100,000 people before the vaccine becomes prevalent.
Yeah. Thank you. So the next question is, what is the cost for testing for COVID for people who are uninsured?
Free. So if you go on the Minnesota State website, just put Minnesota COVID, I think, they'll tell you where the testing centers are. I know there's one in Bloomington. Of course, there's Convention Center downtown Minneapolis. I think Brooklyn Center has one. And you can wait in line or you can get a time and you just go there and spit in the container. Or you can get on the line. I think 20,000 people a day can go online and they mail you from Vault Medical a container and you just spit in it and then send it back, UPS or whatever. And those tests are free. They're paid for by the state. A conventional nasopharyngeal swab, I think, is costing around $100. If you go to a commercial company like Quest Labs or LabCorp, that's about what they charge. The government was going to subsidize, I think, most COVID testing. So I'm not sure of all the economics, but if a patient doesn't have insurance, they can go to the state of Minnesota and get it done for free. And there are clinics all around town.
That's great. And I didn't know that. So
Lauren, I'm going to jump in right here because actually, Dr. Kaufman, that's something I've taken one of those at-home tests because they recommended everyone in my age bracket do it. And just so everybody knows, if you go to the MDH site right now, you can order, they'll give you a link to order the at-home test. And one thing that you want to be sure of if you're doing this, because I ran into this once, is you want to use the link that Minnesota, the health department provides. Because if you go to this site normally and you order a test, they're going to be like, well, that'll be $100. No, it doesn't cost anything. Don't plug in your credit card information. If you go to the MDH site, they'll tell you the same thing. Use the link from the Minnesota Department of Health. They will ask you for your health insurance because if the health insurance won't cover it, that's where the state kicks in the money. They'll ask your health insurance first. But don't enter your credit card information. It is free, even if they ask for it. The reason they sometimes ask for credit card info, I learned, was because other states can also order from this site, and not every state is doing the exact same procedure that Minnesota is. So just so everybody knows, I learned that from personal experience. They are free. You can get them at home. I've done it. It's real simple. You get it, it's next day mail. So you get your results in about 2 days. And, it's real easy. So I would definitely recommend that.
You are supposed to have a Zoom call, I believe, to show that it's you. So you have to follow their whole protocol. And they only allow 20,000 a day. So I've had patients go on and they say they're totally full for that day. So then you're out of luck until the next day. But there are clinics around town, and some are, not as geographically convenient as others. But I think within the metropolitan area, there's at least 3 clinics or 4 within 20 miles.
Great, thank you. It's nice to have that real life experience. Did it hurt at all?
So the actual swab, I had it done to me. For a second, I felt like I was really going to sneeze. I don't think gag so much, but it's just a matter of a few seconds. The spit test, of course, there's no problem at all.
Yeah, I have an uncle who he would consider himself an ox, and he said it was so painful. So then I was kind of like, oh, I'm not going to take one unless I absolutely have to.
Yeah. Okay.
And we just got someone in the chat mentioned that North Memorial has free and no referral. So thanks for that info.
We try to, when people call in the office, we try to get them a time. And so they don't have to wait in line. Now, until a few weeks ago, we had drive-through clinics, but it's got too cold to stand outside and swab people outside. So now you do have to come in. But most of and I think Medicare also, I don't think they charge for most coronavirus because they're under this Coronavirus Act that was supposed to be subsidized by the government.
Okay, we only have time for a couple more questions. So what are some general tips to boost your immune system to protect against the coronavirus, or in general, just boost your immune system?
Well, I think we, pretty much the same things we talked about longevity, but obviously getting adequate rest, eating a good diet. If you can wash your hands frequently, avoid touching your eyes, because we think some of these things can be transmitted through, some viruses can be transmitted through any mucosal surface, which includes your eyes. Obviously, keep your social distance and wear that mask. I think those are probably the main things.
Okay.
All these immune boosters, people have said, should I take zinc? Should I take magnesium? Eating blueberries. I don't think we have great evidence that a lot of those too much to boost your immune system.
Okay, and similarly, if you see other products that are like supplements that, promote helping COVID, is that based in science at all?
I would rather suspect until we have good evidence. I mean, remember initially Donald Trump said we should all be taking hydroxychloroquine. That didn't work out. They added an antibiotic called azithromycin, which is beneficial if you have pneumonia, but it doesn't really work for coronavirus. We do have these monoclonal antibodies when people get sick that they're just becoming available, that if you inject the person with them, they may mitigate the severity, and convalescent plasma, but that's already once you have the disease.
Okay, thank you. And I think what we'll do is we'll just have this last chat question. And thank you everyone for all the questions you've submitted. We really want to be respectful of Ron's time here. So last question, how reliable are COVID antibody tests? And can you go into what an antibody test is?
Two types of tests. There's the antigen test, ANTIGEN. That's when you have the actual virus and we're actually measuring the virus. The problem is all these quick tests you hear people getting are based on a fragment of the virus, and that's an antigen test, and those are not terribly accurate. So you remember the White House tested, and a lot of people we thought didn't have the disease, turned out they did, because you often get false negatives with an antigen test. And if the test is positive, it's probably pretty accurate. Or the football players, they had some false positive tests. I guess that was a different problem. They had got the test contaminated. But the antibody, after you've had the virus, and usually it's at least 2 to 3 weeks later, you start developing antibodies to the virus. And the problem with the antibody testing we now have is we're not sure which antibody we're measuring. If we're measuring the spike protein, that would be great, but we're also measuring part of the body of the virus. And so we're not sure which level will confer immunity. So if your antibody level is 300 in one test and 200 in another, it doesn't mean you're more or less immune than the next guy. Number two is we don't know how long the antibody last in your system. Some people have a rapid decline in their antibody, and yet they're immune because their T cells take over and provide immunity. And we don't have a good way of measuring T cell immunity yet. Other people maintain a very high level of antibody, but we're just not sure if it's the right antibody we're measuring. So the only time I've really done antibody is primarily when people are donating their plasma. So if they've already had a bad case of COVID and they have very high antibody levels, and you go to the War Memorial Blood Bank or Red Cross or whatever, and they say, oh, you have a high antibody level, will you donate your serum? That may be beneficial for people with severe COVID. Otherwise, some people are doing it out of academic interest. Well, I'm not really sure I had COVID. If I have a high antibody level, that probably indicates I did, even though I didn't have symptoms. Remember, about 40% of people never have symptoms with COVID, and yet there are probably immune. So in that case, it might be interesting to have an antibody level, but it doesn't affect the way we treat the patient. We still tell them to practice COVID precautions, and we're not going to give them any medicine if they've already had the disease anyway. So it's, at this point, it's kind of an unnecessary test. It's interesting for population studies where you want to try to figure out what % of the population has already had COVID, but it's not helpful for the individual patient.
Yeah. Okay. So reliable or not, it's probably just better to play it safe and keep following those protocols.
Right. And there's a big difference between all the different antibody tests. So they're not, you can't compare one to the other. So it's not it's not that they're reliable, it's just they're not very useful because they don't give us the kind of information we really need.
Yeah. Okay, well, thank you so much to everyone who's joined us. I would like to say, if you enjoy our events, please let a friend, a coworker, a family member, let someone know. We'd always be happy to have someone new join us. It doesn't have to be a client. So thank you everyone for joining us. Thank you, Anthony. Thank you, Jeff. And of course, thank you, Dr. Kaufman. This has been just brilliant. Very interested in everything you've had to say today. So thanks again. And I hope everyone has a great rest of your week and weekend.
And stay safe.
Thank
Stay
you, Ron.
safe.
Yes. Thank you, Doctor.
Thanks.